And welcome to the longest and also second to last session in the history of medicine. So tonight we're going to be talking about the history of surgery, which you can imagine is going to be pretty dramatic. So we got a lot of drama going on here because surgery is already a pretty dramatic thing. You have to go into a room, convince someone that you're going to slice them open and that they'll be better off as a result of that. That's a lot to ask. So the oldest evidence of surgery we have is trepanation, but it comes up first in the written record, easily through the writings of Hippocrates, and mainly by him kind of forbidding the Hippocratic physicians from engaging in certain types of surgery. So he tried to use things that we've already talked about, bleeding, dietary interventions, herb, cupping, massaging, purging, bleeding, and so on, rather than interventions that were going to cut the body open. And in fact, he specifically forbade the physicians who took the Hippocratic Oath from cutting for the stone. Now, what kind of stone do you think they were talking about back then? What kind of stone were they trying to remove when they cut for the stone? They're bladder stones. So kidney stones are one thing, but bladder stones actually are going to be a further advance on that, and that's what a bladder stone can look like. They can actually build up inside the bladder, take up a lot of space, and compromise the flow of urine to the point where it actually kills someone. So one interesting thing about this is Hippocrates didn't forbid his physicians from cutting for the stone because he thought it was a bad thing, but it was because there were already other physicians that did that. There were already some other medical professionals who did that, and he didn't want his students to kind of poach on their turf, to kind of take over what they were doing. What's interesting, though, is the Greeks didn't really think that cutting into the body was a good thing, so there's a little bit of a ritual when someone would be cut for the stone. The person who did the procedure would get paid, would cut the stone out of the person, and then they'd run away, and the rest of the people in the village would, chase after them throwing stuff, pretending that they didn't actually pay them for the luxury of doing this a few moments earlier. And one reason this thing was not really well liked is if you have to remove a bladder stone, what approach jumps to your mind? How would you, knowing your anatomy, choose to go access the bladder? Let's say it's distended. Let's make it easy. How could you get to that bladder? Over the pubic bone? Yeah, that's what I'd think too. But that's not how they did it. They cut through the stone by doing a perineal approach. So it'd lean the person forward. If it was male, they'd have the person, scrotum would be down, and they'd go right behind the scrotum in front of the anus and cut in, grab the stone with basically pliers, yank it out, suture it up, and hope for the best. So, pretty brutal procedure. Jumping forward, we come back to our guy who we can't get away from, Galen, who did a lot of anatomy research and actually did some surgical work too. He was able to link muscle activity to nerves. He actually cut nerves and demonstrated that that would actually stop muscles from working, and came up with a lot of different ways to explain how the body works. And one thing that he did, apart from getting some things wrong and maintaining that he was infallible, was he made an error that persisted for a long time and had a lot of negative consequences. And that was, he believed that certain types of pus were necessary for healing. He called this laudable pus. So if you cut someone open, they have a wound, maybe it's closing okay. If thick, yellowish pus forms, that was considered laudable or praiseworthy pus. And Galen said that's something you need if you're going to have healing happen properly, because he noted when people had that kind of pus present, they didn't tend to have central spread, they didn't frequently get septic and so forth. And once he moved into high society, he pretty much gave up all that manual labor of surgery in favor of more intellectual pursuits and writing about medicine and writing about how therapeutics should be done. So after the fall of the Roman Empire, we again move into the Islamic empires in the Middle East, also in Spain. And the Quran was interpreted as forbidding surgery at this point. So people were not allowed to cut into the body. So there wasn't a whole lot of surgical advance per se going on in the Muslim countries, although eye surgery was perceived as not penetrating the body, not slicing it open, and that was allowed. However, this ban was not universally acknowledged. There was a guy named Al-Zuhari who was in Cordoba. He was in the area of that's now Spain, called Al-Andalus, and he did write on surgery and various instruments that were there. And one particularly great thing is he made it an illustrated guide. He actually shows some of these surgical implements that were used at the time. I'd really like to know what some of these were actually for. Some make sense, but then that big key-looking block thing with saw blade at the bottom, not quite so sure. But he did do some practical work in surgery, and also said that cautery was useful, burning wounds to kind of help them heal, but also using thread and suturing was useful too. Sadly, that knowledge was not carried forward, and cautery became kind of the standard operating procedure whenever you had to do any kind of surgery, not only in the Islamic empires, but thereafter spreading into Europe as well. So in Europe, we're going to talk about a group of people we've kind of danced around a little bit, and these are the barbers and the barber surgeons. And depending on what country you were in and at what era you were in, you might refer to the same person doing the same thing as a barber or a barber surgeon. The barbers were the people who actually drew blood, did all the stuff that the doctors wanted to have done for diagnostics. So they drew the blood, they gave enemas, they pulled teeth, they cut hair, which we think of with barbers these days. But they also started adding wound healing, or at least wound dressing, to their list of things that they would do. So they would actually have dressings that they would give and would wrap people up in them, and they then after became known as barber surgeons. And what's interesting about these guys is they were mostly illiterate. This was not a high-class profession, but because they had to work with their hands, they had to work with actually dealing with people who were bleeding, they were poised to make some real advances, particularly because some monks were also barber surgeons, meaning they were literate, they could pass on what they learned, they could study and apply it. However, the Council of Tours, which was a church council in the 1100s, basically said that clergy were forbidden from conducting surgery, and so all of a sudden anyone who's literate is no longer allowed to do this. So it kind of became a craft art after that. And it's not that craft arts are bad, but basically information doesn't spread widely. It might spread from person to person, but a lot of times people even look at those things as trade secrets. You don't want to teach how to heal a wound specifically if you find something good, because it's going to decrease your business and your demand if everybody knows it. One quick thing. Because people were illiterate, medieval villages didn't usually have signs with words on them to tell you what sort of thing people did and what business was there. So if you were a barber or a barber surgeon, how would you advertise that you could come get your wounds dressed there? You'd take a bloody rag and you'd wrap it around a stick. And hence, we still have the barber pole today, very stylized bloody rag wrapped around a stick, basically saying like, hey, if you got a wound, come check us out, we can wrap you up. So barbers and barber surgeons were doing a lot of the manual labor of medicine, and some of the surgeons, starting in Paris, decided they wanted to become more high status. They wanted to become more intellectual, and so the College of Surgeons in Paris basically said, well, we're just as good as physicians, and we're going to wear long robes, and those pesky barber surgeons, those illiterate guys, they'll wear the short robes, and we're just going to kind of pretend to be like physicians. And basically they adopted the worst of the physicians, an over-reliance on authority, not actually dealing with patients, and didn't get any of that manual know-how that comes from actually treating people. So they really kind of were the worst of both worlds. The English barber surgeons were interesting in that they were rigidly defined as having a single guild early on, and they were also separated into barbers, the people who did the tooth pulling, bleeding people when they needed to have some blood drawn, cutting their hair and shaving them, versus academic surgeons who actually did the more advanced things, treating wounds and amputating legs or arms that were kind of broken or had compound fractures. So a compound fracture back in the day was basically a death sentence, but occasionally they would try to amputate in the hope that somebody would actually pull through. But we're far away from antisepsis just yet, so pulling through was going to be very dicey and very unlikely. So the Middle Ages usually get a bad rap, and that's partially deserved. It was not a complete intellectual wasteland, but it really didn't stack up to the Greek predecessor time as well as the following Enlightenment and Renaissance time. But there were a few people who were making contributions, and one French surgeon, Guy de Chaloc, was actually one of the medieval surgeons who made some advances. He did a few different things that were interesting. He actually caught the plague and survived it, and then wrote down how to distinguish the different forms that the plague takes. We now know it takes a septic form, going through the blood, has a pneumonic form, goes through the air into the lungs, and a bubonic form that tends to spread through the lymph nodes first. He advised the Pope, who was actually staying in France at that time, a guy named Clement VI, to keep some fires burning in his chambers and not to leave. The fires were meant to purify the air. Chances are really good it didn't do that, but having the Pope not leave those chambers was a great way to make sure he didn't have exposure to infection, and the Pope did not get the plague and was very happy with his advice. He wrote a 7-volume text on how to actually carry out surgery. It was Chirurgia Magna, and you'll see surgery spelled with a CH a lot, so chirurgia, that was just an older way of saying surgery, and was very familiar with all the predecessors, but really kind of tried to pick and choose the best he could, but he maintained one of those errors that Galen propagated, the one I mentioned earlier, that you had to have laudable pus for healing. Now, that doesn't sound awful right off the bat. Like, oh, okay, they got that pus, it's okay. The problem is, if they did a procedure and somehow it actually managed to heal really nicely, but there was no pus, they'd reopen it until they got pus. And just as there's laudable pus, there's also not laudable pus. Stuff like strep, Clostridium, things that are going to actually kill the person. So that error wasn't just innocent. It wasn't that they saw that pus and thought, oh, that's good. They would actually go try to induce it if it wasn't already there. And you had healing by what's called first intention, the actual healing that goes well. Now, the big name, moving from medieval into early Renaissance surgery, was another Frenchman. His name was Ambroise Poiret, and he was literate, but he only spoke and wrote French. He didn't speak Latin, and that kept him from higher level training and being one of the academic surgeons. So he did what a lot of people have done before when he didn't have too many options, is that he actually joined the military. He wasn't able to get in with the academic surgeons, so he became a barber surgeon in the French army, and he kind of was typical of those early Renaissance thinkers who decided they would actually try new things, would actually experiment a bit. Now, real quick before we get into his experiments, I just love the fact we have his book here, and initially it actually had this picture on it. This is called a wound man. So it's just showing this person being clubbed and speared and arrowed and macheted, whatever else. This is another way of advertising, basically saying like, hey, buy this book and you'll know how to treat all these things, rather than one person being on the receiving end of every one of those problems right there. So Poiret joined the army, and he refined surgical techniques as he was working, but what's really fascinating is this was right after gunpowder had been introduced. And we're going to see this a lot, that new methods of warfare lead to medical breakthroughs. It's not the best thing, it's not a great association, but basically as we find new and more interesting ways to kill each other, we find new and more interesting ways to heal each other because we have to deal with those injuries. And gunpowder led to bullets, and he was one of the people who had to deal with retrieving bullets. Now at the time, the major problem wasn't thought to be the bullet inside the person, it was that the gunpowder was toxic, and that the gunpowder toxins were going to kill the person. So they would pull out the bullet, and then to neutralize the gunpowder toxins, they would pour boiling oil into the wound to neutralize the gunpowder toxins. Perfectly sensible, right? So he was doing what he was supposed to do as he was trained, and he actually ran out of oil during a battle, and he thought, oh no, this is terrible. I'm not going to be able to treat my patients. So he came up with a poultice instead. He said, well, I'll come up with something else that'll soothe the wound. He used egg whites. He used some turpentine, just kind of threw together what he could find that he thought would soothe it. And interestingly, he compared the next day. He thought he'd probably written these people's death certificates, but instead he found that the people he treated more gently were healing better. Now, rather than just discounting that or saying like, oh, it must have been their humoral balance, no big deal, he actually went with that. He started making that the standard of care that he would treat people with, and actually deferred to his experience over the older authorities and the people who had been telling him what to do. And he started that and then just ran with it. Took a very experimental approach to dealing with people. He brought back suturing rather than cautery. That was one of his big advancements. It wasn't something he invented, but he brought it back into form, and he became very famous. He actually wrote 20 books, and they became surgical kind of classics for almost 200 years. Introduced ligature, studied syphilis, fractures, dislocations, and he decided that the practice of curing inguinal hernias by castrating people wasn't actually the way to go. So yeah, indirect inguinal hernia, standard of care, castration. Think about the anatomy. Is that going to solve anything? No, it's just going to make it so much worse. So looking and finding ways to improve surgery was one of the things that Paré actually really brought to the table. And one of my favorite stories about him is he was very effective, and people knew he was effective. Soldiers don't really take time to praise people up and down just because they're high status. They like results. So when the army at a city called Metz was besieged, they actually smuggled Paré into town to treat the soldiers there, and they actually carried him through the street like a parade because they were so happy he'd shown up and would actually take their wounds and their treatment seriously. So he was, a fairly kind of a celebrity physician, celebrity surgeon, but he actually proved his worth by results, not just by status. So I already mentioned that war and surgery go together. Most of the time when we talk about ancient battlefields, injured soldiers were not a problem. They were just left to die. If you didn't make it off the battlefield, well, you were either speared by peasants and your stuff stolen, or you just died slowly of sepsis or whatever else might kill you. So in the 1500s, we've got Paré introducing arterial ligature and amputations near the battlefield, actually trying to get these things closed early, leading to better outcomes. So actually getting people treated rather than leaving them to die. And jumping forward, we've got wartime leading to some other things. We mentioned that Washington mandated inoculations of smallpox for the troops in the Revolutionary Army, and that's thought to have actually kept the manpower of the Army high enough that we were able to actually last through the Revolutionary War. 1850s, probably heard of Florence Nightingale, who kind of pioneered modern nursing techniques. This was during the Crimean War with Britain over in the Ukraine, and finding ways to make sure that people were recovering in a way that would actually help them recover, not just being brought to a hospital then die of sepsis. American Civil War, we always think of the brutality of it, and it was brutal, but patient transport from the battlefield and even anesthesia. We always think about people biting a strap to get their legs amputated. Anesthesia, and we'll talk more about it, did exist in the Civil War. It just wasn't enough. It was hard to get that equipment close enough to the battlefield to be practical. And in the Franco-Prussian War, we actually moved from inoculating with smallpox towards vaccination using cowpox to make sure that smallpox doesn't break out in the close confines of a military camp. And in World War I, afterwards, we started working on facial reconstruction and prostheses so that people could actually be more functional after the war. A book came out last year. It's actually really fascinating, called The Face Maker, about the people who were most involved in making these prosthetic faces for people who were disfigured during World War I. And then in the 50s and 70s, Korea and Vietnam brought the idea that you can get people off the battlefield quickly to a field hospital. And rather than trying to treat them on site, if you could get them out of there quickly enough to a controlled environment, outcomes would be better. And that's also when we started understanding that PTSD and the mental aspects of war would also have long-lasting effects. All right, so we're now learning things about how diffuse axonal injury, concussions, contusions can actually lead to long-term neurologic problems, as the wars in Iraq and Afghanistan had a lot of improvised explosives that would cause shaking, jarring, sudden motions of the head, and a lot of neurologic damage that doesn't necessarily manifest at the time, but builds up gradually. Real quick, what do you guys think the first war was? It's an American war, but what was the first American war where more people died due to combat than hygiene? I'm jumping ahead a little bit, but let's just go for it. What's the first war America fought in where more people died due to combat rather than poor hygiene, bad food supply, bad medicine, and so forth? You've been here before. You don't get to answer. What do you think? Throw some answers out. Civil War, okay. Any others? Korean, 50s, all right. World War II, okay, we're bouncing. It's actually the first Gulf War, 1990s. That's the first war where food, hygiene, and everything else in the military was at such a high standard that we actually didn't lose people to that. And we didn't lose that many soldiers in combat in the first Gulf War, but the supply lines and hygiene have gotten so good, that was actually going to be the main thing. So yeah, there we go. Gulf War, 1990s. All right, so Poiret was so well received that the French king basically said, hey, academic surgeons, he's better than you. You need to let him into your little club. So they waived their Latin examination, and he was allowed to become an academic surgeon and had kind of the status that came with that. During, there was a wedding ceremony where the French king, Henry II, was getting married to the daughter of Philip II of Spain. And what's interesting is Henry II had actually been a captive of Philip's father, so I can't imagine this was the most comfortable social arrangement, but he'd been a captive during wartime. But his daughter was going to get married to Philip II, and there was a jousting tournament, and Henry II was actually speared during the joust with an accident happened, and the spear went through his visor and up through his eye socket and through his brain. But this didn't actually kill him immediately. He lingered for a while. So Ambrose Poiret was there with the French king, so he got to work trying to figure out if they could in any way save him. So they took some condemned criminal skulls, rammed a jousting rod through the same way to see if they could figure out what went wrong. But he was helped because Philip II's court physician was also there, and they worked on the problem together. So Ambrose Vesalius and Andreas Vesalius and Poiret worked together in the same room to try to figure out the problem. So a lot of people have an idea where they'd go back in time if they could. This is where I'd go. I'd go hang out in this room and try to, kind of politely observe these two at work, trying to figure out how to save not Philip, but Henry II. Sadly, this was a massive head injury. Infection took hold as well, so he died. But they did attempt some experiments to see if there was any way they could come up with to save him following that injury. So we've got physicians, we've got surgeons, we've got barbers. They're all kind of sticking to their own track. They're all in their own lane. And Henry VIII of England then kind of chartered the barbers and surgeons together. Now, if you don't know anything about English history, when I say Henry VIII, that may not mean anything to you. If you think of famous British king, he's probably the one you're thinking of. Had all the wives, sent them to death, all that jazz. So he's probably the most famous English king. He chartered the barbers and barber surgeons together, and the English surgeons received 2 bodies for dissection per year. That was their total allotment. The Scottish barber surgeons only got 1 body per year, but don't feel too bad for them. To underwrite their expenses, they were given a monopoly to distribute whiskey in Edinburgh, Scotland. Do you think, anybody know the Scottish stereotypes? I'm kicking my own people here, so it's okay. Yeah, Scottish stereotypes, like your whiskey, all right. So I think they probably did okay for themselves. So the University of Edinburgh actually became a major hub for surgery and anatomy teaching, and as a result, it became a major hub for body snatching. Because of all the needs they had, and they were given 1 body per year officially, they needed more, not donors, they needed more cadavers, and they stole them. Now, the Edinburgh Medical School had 3 generations of the same family teaching anatomy there in surgery for 126 years. So you had Alexander Monroe the First. He was considered to be a really good anatomist and surgeon. Alexander Monroe the Second, even better than his dad. And Alexander Monroe the Third, absolutely terrible. So he got in there. He's a true Nepo baby. He just got in, would apparently just read from his grandfather and father's notes, barely did any research, barely did any teaching of his own, just read through their notes. One of his students was actually Charles Darwin, and he said that, he hated this man with a passion because he was such a lazy teacher. All right, so body snatching became very, very prevalent anywhere near a med school, but Scotland especially. People would do what are called, they'd put mort safes around their grave. So they would actually have cages around their grave to prevent people from stealing the body. After 2 weeks, they'd be removed because the process of decomposition would have been enough to stop it by then. But bodies were being sold very frequently, sold to anatomists, sold to surgical schools. And two guys, Burke and Hare, decided, we really should cut out the middleman. And instead of waiting for people to die, we should just kill them and send them to the anatomy schools. So Burke and Hare, I think it was Burke, he and his wife ran a boarding house. One of their lodgers died unexpectedly without paying his bill. So they just took his body to the anatomist, got a lot of money, and thought, we really could do pretty well for ourselves this way. So they started selling bodies to the anatomy schools. They were eventually found because they got pretty bold about it and were like, there were some pretty well-known poor people who did, shows and were entertaining. People around town knew who they were, and all of a sudden they started showing up on the slab in the anatomy schools, and they're like, that's Jimmy. Why is Jimmy on the table? So they were eventually found out. By the way, there is a comedy movie starring Simon Pegg and Andy Serkis out there called Burke and Hare. I highly recommend it. So if you like morbid humor, that's the way to go. Eventually, they were caught. They were way too brazen about it. Hare turned evidence against Burke, and Burke was executed. And back then, people were a big fan of poetic irony for justice, so his body was sold to the surgeons, and they took his flesh and bound books out of it, made leather out of his skin, and his skeleton still hangs in the anatomy school, the College of Surgeons Museum in Edinburgh. So you can go see it there to this day. So we have two other Scotsmen, but they became more famous for their work in England. They were from Scotland, but this is going to be William and John Hunter. Now, William Hunter was a surgeon, but also an obstetrician, and he moved to London and became very successful. And he started opening an anatomy school because anatomy teaching was very uneven. And back then, there were separate private anatomy schools. So they'd set up shop near a medical school. The medical anatomy lectures are basically some old person sitting at a podium, droning on and on about stuff. That'd be awful. Oh, wait. But they were just pretty much terrible, no emphasis on teaching. So private anatomy schools existed that the students would go to after hours to learn anatomy, view it on a cadaver, see somebody who actually knew what they were doing, demonstrate the anatomy. And so William Hunter moved to London, set up this anatomy school, had a rousing practice of his own. So he brought his younger brother, John Hunter, in to work as a prosector. And John Hunter had a very little propensity for academia. He was not a good student. He just wanted to go outside and observe nature, but he was really, really skilled with his hands, and he was a genius when it came to actually interpreting how things work. He just was not a good student. Tried to go to college, washed out, but he took over the anatomy teaching at his brother's school and was pretty soon doing all the work himself. He was unable to practice without going to school, but he really didn't feel that he was cut out for the college life, so like Ambrose Paré, he joined the military and operated as a military surgeon, toured around, and then eventually came back to London. His brother helped him get in with some famous surgeons at various hospitals there, two guys named William Chesterton, who came up with lithotomy, removing bladder stones and kidney stones, but actually doing a good job of it, and Percival Pott, one of the early orthopedists. So John Hunter was able to really find a way to practice surgery that played to his strengths, actually doing things rather than being in the classroom. So he eventually parted with his brother, started his own anatomy school, started his own private practice, and he was phenomenally successful. And he worked like a dog. It said he worked 19 hours a day. He would wake up, write, dissect, go visit patients, work in the hospital, come back, write up research, work with students who lived in his house. And his house was basically where he taught, and he had a huge house, and it was basically an anatomy factory. They had bodies coming in the back, being dissected, being sent back out, and he turned body snatching from kind of a craft little side thing into like an industry. Bodies were being stolen all the time, and it was largely to supply John Hunter with enough donors. I shouldn't use that word, sorry, conditioning, enough bodies of people who were stolen from their graves to carry out those researches. I find John Hunter fascinating. He's one of my heroes, but in terms of ethics, he's absolutely horrendous. I mean, the stuff he did and his brilliance is unquestionable, but he would do anything to get a specimen that he wanted. And that's, most clearly shown in the story of this guy named Charles Byrne, who was someone with gigantism. He was from Ireland, and back in the day, you didn't play basketball or volleyball. If you were super tall, you had an option to go put yourself in a sideshow and exhibit yourself in front of the public. So kind of like a circus. And John Hunter went to see the traveling show, saw this gigantic person, 7'8", and said, when you die, I really want to get your body. And Charles Byrne didn't like that. He was a very staunch Catholic. At the time, it was considered your body had to be intact for Resurrection Day. And so he knew Hunter would stop at nothing to get his body. And he was in bad health. He knew he wasn't going to live much longer. So he paid a mortician to bury him in a stone coffin and drop that coffin into the sea. John Hunter counter-bribed the mortician, followed them out of town, and when they stopped at a pub, they swapped out his body with some rocks, and then his body was traveling back to London with John Hunter, and his skeleton was in his lab for many, many years. So, yeah, amazing person, ethically, but get this. He did just as much work on comparative anatomy as he did in human anatomy. This is not a museum. This is his house. That's his house. You have a whale skeleton, you got all these animal skeletons there, and basically he also had a country estate where he'd keep exotic animals. And he wouldn't kill them to dissect them, but after they died, he would dissect them, mount their skeletons, and so forth. He actually had all these animals running wild on his country estate. The guy who wrote Dr. Dolittle lived a few miles away, and it's thought that Hunter was actually the inspiration for Dr. Dolittle. So take that where you want. That whale skeleton served as the inspiration for Herman Melville to write Moby Dick. Because who's read Moby Dick? Who's suffered through it like I have? Okay. In the middle of it, there's a whole chapter on whale anatomy. Boom, out of nowhere. And that's all because of John Hunter. So Melville was inspired by that. So his comparative anatomy dissections filled his house. And after his death, he donated them all to the College of Surgeons, and there's now a Hunterian museum. It's been refurbished. I think it's reopening again this year, but it's in the UK, and it's there with a lot of these specimens still intact. He actually came up with the idea that animals had in fact gone extinct. He knew that mastodon teeth were not the same as elephant teeth. This was actually fairly controversial at the time. Extinction was not something that was considered possible. And he did not come up with evolution by natural selection, but he got real close. But that was considered so controversial that when he sent in a paper hinting towards that, it was kept under wraps by the Royal College of Surgeons, and only after Darwin wrote and published on the origin of species did the Royal College of Surgeons rush out this paper 70 years after the fact to be like, oh, by the way, Hunter thought of that too. So he did a lot of things. He came up with the terminology we use for dentistry. If you've ever heard of bicuspids, tricuspids, and so forth, he came up with that terminology and worked with the dentists in London to try to make dentistry even more suitable as a career. Surgeons were considered lowbrow. Dentists were considered the bottom of the barrel. They were not socially acceptable at all. But because Hunter put all this scientific work into making surgery more effective and making dentistry more effective, he brought all those areas up. He did a lot of auto-experimentation as well. He tore his Achilles tendon one night when he was doing jumping jacks to stay awake because he was writing late into the night. And as soon as he tore his hand, his calcaneal tendon, he kind of hobbled to his desk. But then he thought, I should do this to some mice and see how the healing proceeds as this tendon tries to regrow. So he followed how tendons are going to regrow, kept track of it on himself as well. A big controversy at the time was whether chlamydia and syphilis were one disease or two separate diseases. And to track, it wasn't known if they were just manifestations of one disease or kind of they had different variants. So, like a dedicated scientist, he met up with a sailor at a bar. Sailor had syphilis. Hunter took some of the syphilitic pustules from the man's penis and cut his arm and scratched them into his own arm to give himself syphilis and describe the progression of the disease. And he came to the conclusion that chlamydia and syphilis were in fact the same disease. So he was wrong, probably because the sailor had both syphilis and chlamydia at the same time. But he did that to himself. He had heart problems and he actually died of a heart attack. He knew what was coming. He knew that the angina and the tightness in the chest he felt was going to be his heart. And he was in an argument with some people at the hospital where he was working, and he suddenly felt the angina really hit him hard, and he ran to a mirror and started writing down the symptoms that were appearing, the paleness, the sweat, and so forth, and he dropped dead of a heart attack at that point. So basically, scientist par excellence, just never let anything stand in his way, not money, not morals, anything, to find out what he needed to do. So again, I find he's one of my heroes, but there's a huge asterisk after that. I don't think I'm capable of going to all those lengths. Well, okay, we'll see. But it was because of people like Hunter that surgery very gradually became more and more respectable in England. It actually had a scientific basis behind it. The outcomes became better. And, you guys are all here at this talk, so I'm assuming it's going to be a large number, but who here is contemplating a career in surgery? Several, okay. Now, who here has worked as an EMT? Oh, good, several. Okay, EMTs, this one's for you. Do you feel that EMTs are treated with respect and admiration and societal approval for their hard work and their expertise? Go ahead and answer. No. Everybody's made jokes or heard those jokes. It's like, oh man, those EMTs come, I'm going to crawl into the hospital before I let them get me. EMTs are trying to save your life. Come on, they're skilled people. But that's where surgery was, if not lower, back in this time. People would go to the surgeons as an absolute last resort. And in one generation, you go surgery from being this incredibly suspect career that your parents would not admit to their children doing, to all of a sudden be like, oh, Jimmy's going to be a surgeon. That's actually a good thing. And so that happened very gradually in England, and maybe someday EMTs will be living the same dream of that high status approval for their hard work. That'd be great. In France, it was different. In France, respectability for surgery came instantaneously, and it's because King Louis XIV was very sick. Now, just like Henry VIII is that famous king of England that you're probably thinking of, if you think of famous French king, you're probably thinking of Louis XIV. He was king for a long, long time, but medically, he was a disaster. It's said he bathed twice in his life. He smelled so bad that people had to throw windows open whenever he entered the room. And among many other things, he had anal fistula. Now, what are anal fistulae? It's an opening from your rectum to the outside that bypasses the anus. Prone to infection, prone to sepsis, prone to irritation. And so he told the court barber, this guy named Charles-François Felix, he said, you need to fix this. You are going to conduct surgery, you're going to fix these, and that's that. So there we go. Anal fistula. Felix decided that he had to figure out a way to do this, and so he experimented on peasants who had anal fistulae. None of them survived. And then the day came, he had to do the procedure on the King of France. So the King of France came in, bent over. Felix had done the procedure several times, just not successfully, but it worked. He was able to fix the anal fistulae, open them up, close the wound. Anus worked after that. And the King of France, Louis XIV, said, oh, you surgeons are all right. Let's make you a baron, and now all universities will have surgery departments and so forth. So it became instantaneously respectable. Now, I think probably he figured out the nuts and bolts of this surgery pretty well on the peasants. But before you operate on the anus of the King of France, what do you probably do with your instruments? You probably clean them. You want them to be nice and shiny. You don't know anything about bacteria or sepsis, but you make them nice and shiny so it looks good, and that probably is what saved the king's life. So chairs of surgery were endowed, surgeons became instantaneously respected professionals, and eventually they were put into the army as well. And they were relatively high status until the French Revolution, at which point the distinction between barber, surgeon, physician was broken down, and the revolutionaries just said, okay, health officer is what we have now, and these people will handle the various aspects of treating the population. So surgery is gaining in prestige. People actually are interested in going into it as something other than desperation. So it's nice that you have people going into it willingly who don't hate their job, but it's still brutally violent. Post-surgical infection is absolutely rampant. People are still dying. People do not want to get surgery unless they absolutely have to. So the surgeons were generally going to be working in towers in the hospitals, far away from the other patients. Why were they far away? You don't have to hear the screams. And there are still some hospitals that you can tour where they still have those old surgical suites present, and they're far away from the rest of the hospital. You couldn't anesthetize people, so orderlies, big burly guys, would basically hold them down, and the surgeon had to do the cutting. How are you going to cut? Are you going to be slow, methodical, and precise? No, you got people jerking, pulling away, screaming. There were people who would get partway through a surgery and run out of the room because they outclassed the orderlies and would run down the hallway with limbs hanging loose, bleeding, and so forth. So the idea of anesthesia and later antisepsis are what made surgery practical. And the first thing that really kind of came and made itself available was anesthesia. Now, the main thing surgeons had to deal with was speed. That was the one variable they had control over. So they tried to operate fast, fast, fast. But alcohol was still present. Opium was known. But, alcohol and opium, they can distract and dull the pain, but they're not going to make it go away. And really severe pain is not going to be touched by what they had available. So a French surgeon in, I think it was actually Borodino, was in the French-Russian War. He noticed that a lot of the soldiers who were coming in for amputations, who'd been sitting out in the cold because he could only do one at a time, the ones who'd actually been on the cold and practically frostbitten did really well with the amputations. They didn't feel it because the limbs had basically been frozen. So he started trying to bring ice with him whenever he would do amputations because he thought, okay, I can actually numb people and be doing the surgery that way. So he tried to actually use that. Bringing ice with you everywhere is not going to be terribly effective in the 1800s, but he also got the idea that horse-drawn ambulances could get people off the battlefield quicker and triage wounded people. Triage was actually one of his contributions. I don't know if he invented it, but the idea that you have to look at the people who are going to survive and treat them before you go down the line of people who are much more dire circumstance. So we finally get to surgical anesthesia in the 1800s. Now, back then, we didn't have TV, there were no movies. For fun, people just had to do whatever they could. And one thing people did for fun back in the 1800s was they'd go to laughing gas parties. So, nitrous oxide, which had been discovered 60 odd years ago, was discovered in 1772. People would go around, they knew how to mix it, and they would fill kind of gas bladders full of it, and they'd invite people up on stage, they'd suck down nitrous oxide, and they'd act really silly, everybody'd have a laugh, and they just kind of had these laughing gas parties. A dentist named Horace Wells went to one of these, and on his way back to his seat, there's variations on this story, but most commonly it said he kind of rammed his knee into a seat as he was sitting down, but he didn't feel anything. He didn't feel the pain until the next day, and he thought, I might be able to pull teeth using something like this. If I didn't feel that pain, maybe I could dull people with nitrous oxide and pull teeth. And he did. And it worked pretty well. He was able to come up with a pretty good method of doing it. And he thought, maybe we can take this further. Maybe we could do surgery with nitrous oxide. So he went to Boston General and a very famous, very well-respected surgeon named John Warren said, okay, you can, administer this to a patient I have coming in who's going to have a procedure done. The patient canceled, and so Horace Wells offered to any of the med students, he said, well, does anyone need a tooth pulled? Why don't you come up, or come down rather, because it was an amphitheater. Come down, I'll pull your tooth, and you'll see painless tooth extraction. And the story goes, you can actually go to where this still happened. It's in Boston. But he pulled the tooth, and the person who got the tooth pulled said that he didn't feel pain, but when it came out, he let out kind of a yelp. And med students then were boisterous. So they just started catcalling this guy, like, you suck, things like that. And actually, I guess the pivotal no coming back from insult back then was humbug. And so he fled the surgical theater in disgrace. No one took that seriously. But a student of his, a guy named William Morton, said, there's really something to this. Maybe I could try ether, because in addition to laughing gas parties, there were something known as ether frolics, where people would sniff ether. They'd basically pull the ether in, they'd get silly and act high, and then people would, have a good laugh. So he started using ether for anesthesia in dentistry, and almost a year to the day, he talked Dr. Warren into doing the same thing again. He said, I'll come in, use ether anesthesia. He didn't call it that because he wanted to patent it, but he said, I'll use my Letheon, which is what he called it, to anesthetize your patient. Now this time the patient showed up and he had a salivary gland tumor, probably a submandibular tumor based on the description of it. Imagine trying to do a tumor removal on somebody who has to be held in place and is conscious the whole time. He administered the anesthesia. It's actually in a glass like that. And it worked. The guy passed out. He monitored him. If he started to stir, he gave him a little more ether. And after 25 minutes of surgery, the guy finally woke up. And apparently his first words were, when are you going to start? So this was obviously a huge deal. Painless surgery had arrived. People were aware of it. John Collins Warren was a very well-respected surgeon, so he was in a place to promote this. And what did he tell his students? He said, gentlemen, this is no humbug. I don't think we could pull it off, but if you guys can bring humbug back, you would make me so happy. If humbug can come back, that would make me smile. So, everything's going great. We know how to create surgical anesthesia. It's ether. Everyone has access to it. This is fantastic. Should be great. Here's the problem. Morton had a long history of being a con man. He had bounced from town to town, running credit schemes, getting stuff on credit, selling it, and leaving town before he could get called on it. He really wanted to get rich quick, and he knew he had something here. So he disguised the ether as Letheon, added some color to it, some perfumes, because anyone in the know knew that it was ether. One of the people he'd worked with in the process of coming up with the process was a Harvard chemist named Charles Jackson. Now, Charles Jackson was his own brand of dysfunctional. He said, I want equal, if not more credit, because I'm the one who helped you with this. And Jackson was really touchy about priority because he said Samuel Morse had stolen Morse code from him. Alfred Nobel had stolen TNT from him. So he was damned if he was going to let this guy steal surgical anesthesia from him. So the two just started attacking each other in the press nonstop with, I have priority, I figured it out. No, you didn't. And so this became a national embarrassment. Now, word that ether could be used for anesthesia spread instantly. So it was basically the cat was out of the bag, but these guys were still fighting for who had priority. And the U.S. government put up $100,000 in 1880s dollars to whoever could prove their precedent. So Morton jumped in his horse-drawn cab, but on his way to D.C., he had a stroke and died. Now, according to a medical historian, a guy named Sherwin Newland, he's a really good read. Years later, Charles Jackson was in the graveyard outside of Cambridge, Massachusetts for a funeral and came across the tombstone for Morton, this man he hated above all else. And what did he see on there? William Morton, inventor and revealer of surgical anesthesia, by whom pain in surgery was averted and annulled, before whom in all-time surgery was agony. According to Sherwin Newland, Charles Jackson instantaneously went acutely psychotically insane and never recovered, dying in an insane asylum years later, and coincidentally buried in the same cemetery. So we've got these guys taking the first massive major medical advance Americans were responsible for and turning it into a circus. And one final note that came out shortly thereafter is that 4 years before Morton's demonstration in Boston, a rural practitioner, a guy named Crawford Long in Georgia, had done ether anesthesia to remove small tumors, little amputations of fingers, and short operations. And he really wasn't seeking the glory. He was content to be a rural practitioner, but his friends were like, Crawford, that's like $100,000. Come on, you got to tell people you did this. Nobody ever got the money, although Crawford Long, being a dignified person, actually died delivering a baby, passed the baby to his nurse before he dropped dead, but at least did not, sully his reputation as everybody else involved in the case did. I should mention the first guy, Horace Wells, who came up with the idea of nitrous oxide anesthesia, kind of lost his mind as well, went to France to try to press the claim that he should be rewarded for having come up with the entire concept of anesthesia, was told to go packing, and eventually was arrested for throwing acid on women in New York City, thrown in jail. He smuggled in some chloroform, which he'd been experimenting with, and slit his femoral veins and arteries and died. So yeah, nothing good came from anesthesia, even though it was such a huge advance. So the knowledge that ether could be used for anesthesia spread really rapidly. And one of the quick early adopters in the UK was a guy named Robert Liston. Now, he was in Edinburgh, and he was a very famous surgeon, but he had really wanted to try to find ways to improve surgery. Despite his status, he never stopped trying to get better at it. He tried mesmerism, using actual post-hypnotic suggestion to get people to a painless state before surgery, and he actually got it to work. But it took a long time. It took hours to kind of get these people into a trance where they could actually have the surgery proceed. He found out that ether worked really, really well. And in terms of old-timey dialogue, I have one more favorite from him. "This Yankee Dodge beats mesmerism hollow." Now, translation, for those of you who didn't grow up listening to grizzled old prospectors talk, Yankee, American, Dodge, trick, beats mesmerism hollow, does much better than mesmerism. So, there we go. Again, if you guys want to start talking like that any day now, I would be so happy. That would be just great. So he was a really well-known surgeon. He was actually renowned for the speed of his amputations. He could do a lower limb amputation in 2.5 minutes, but speed has problems. He actually was, he's kind of famous not for his skill as much as he had a surgical procedure with a 300% mortality rate. Can anyone envision how that happened? All right, he was doing a high thigh amputation. He had his assistant clamping down on the femoral artery. He had people pull out their watches and said, time me, see how fast this goes. So he got his knife ready, Felsform knife, got it all around, cut the leg in one big cut. But he also cut off 2 of the fingers of his assistant who had gotten in the way, and the assistant jumped bleeding, and Liston kind of jumped through his knife, and the knife flew into the audience who was watching the surgery, didn't actually stab anyone, but caused one of the elderly surgeons in the audience to have a heart attack and die. The patient and the assistant later died of sepsis from the wounds, so one procedure, 300% mortality rate. Yeah. Now, Robert Knox, I didn't actually mention him by name, but he was the anatomist in Edinburgh who was getting bodies from Burke and Hare. He was the guy who Burke and Hare had been selling bodies to. Robert Liston actually got into a fight with Knox in his classroom after he realized that acquaintance of his, kind of a homeless woman who was kind of well known among Edinburgh, had been killed by Burke and Hare and was being dissected in Knox's lab. So just imagine Dr. Pankey coming up here and punching me in the face, and you'll have an idea about what that was like. These 2 guys just had a fist fight in front of all the students. Now, anesthesia with ether worked pretty well. The problem was I want to say volatile. Yes, it's volatile, but it was volatile in the figurative sense also, meaning it was hard to titrate just how much you needed. It was kind of a really fine line to walk between too little and too much. And other people, this guy especially, James Simpson, thought, we should actually see if there's other things that would work. And so he and his friends actually started a little anesthesia society where they would meet up for dinner and then they would sniff various chemicals and see what happened to each other. The old days were wild, man. There we go. So they got chloroform and they decided to try chloroform. And the description goes, they said, oh, let's sniff this chloroform. And the next thing was they all very groggily got up off the floor and threw the windows open because they basically didn't realize how potent chloroform was. And it became the go-to for surgery, but also childbirth. It became very common to use chloroform during childbirth. This caused a lot of controversy, not just because of the scientific basis. Chloroform was a little more aggravating. It was irritating, and it would occasionally people would just drop dead. Something about chloroform, people who were hypersensitive to it, very small minority of people, but it would kill them. Other people said, well, you can't use this in childbirth because it would, quote, rob God of the deep and earnest cries of a mother in labor. So there were, quote unquote, moral grounds for not averting pain during childbirth. However, as we saw with Henry VIII and Louis XIV, once royalty does it, everybody shuts up. And debate ended because Queen Victoria delivered one of her children, Prince Leopold, using chloroform anesthesia, and it was actually administered by John Snow, the same guy who figured out that cholera was spreading from the Broad Street pump. So he administered anesthesia to the Queen. After the Queen did it, everyone stopped negatively commenting on it because you don't say anything negative about what the Queen chose to do. All right, so we've got surgical anesthesia. The next problem we have is microbes. We don't even know that there's microbes. We just know people die of infection after surgery. Liston had a student, more of somebody who wasn't a formal student, but he was present when Liston first used ether, and he was a Quaker, and his name was Joseph Lister. And quick spoiler, yes, Listerine is in fact named after him. So Joseph Lister had a skill set that almost no one else at the time did. He was a really good microscopist. His father was actually a well-known scientist who had figured out how to prevent what's called chromatic aberration. And long story short, different wavelengths of light refract at different angles, and old microscopes would become blurry. You'd kind of have a rainbow blur because of those different refractory capabilities. His dad actually figured out how to make lenses that would correct for that, and you wouldn't have that chromatic aberration. But he grew up using microscopes, and he started wondering, after he read Pasteur's work, that if these little quote-unquote nanomolecules, these small little entities that caused food to rot, caused the beer and wine to go bad in France, if they might be responsible for the various types of surgical infections that he saw. So he started examining the pus from different types of wounds that the patients had, and lo and behold, he found that when you had certain types of pus, you always had certain types of what we now know to be bacteria. That laudable pus, that pus people wanted to see, that was staph. It forms thick pus. It doesn't tend to spread centrally. It stays near the infection site. It's not awesome, but it's better than the smelly, thick pus that comes from strep, and much better than the watery, purulent, nasty-smelling gas gangrene that you get from clostridial infections. So he found very readily that different bacteria were involved in these and thought to himself, well, maybe there's a way to get rid of these things that are causing these problems. So he started looking for antiseptics, things that would actually kill these bacteria, and he settled on what was called carbolic acid at the time. We were more familiar with it as phenol. So he'd spray it on his hands, he'd spray it on his instruments, he'd spray it into the opened wound of the patient. And phenol is irritating. It's a bit of a carcinogen, but that was not really something that was appreciated at the time. And it's a weak carcinogen. I'm not trying to downplay it, but it's not one that's so bad. And he had great results. He was able to actually fix compound fractures, which generally were going to be, if somebody had a closed fracture, it could be set and they'd heal, but a compound fracture was almost a death sentence because once the bone pierced the skin, bacteria had a clean entryway into the body. But he was able to apply the phenol, the carbolic acid, to these wounds, set them, and people survived. He had a very good survival rate. But if you've been paying attention for the last several times, you'll probably realize he's fighting a lot of institutionalized apathy, not apathy, but inertia. This is the exact opposite of what a surgeon is supposed to be. Instead of being fast, cavalier, kind of a cowboy, you're asking these people to slow down, spray this irritating thing on their hands, on their instruments, and so forth. It smells bad. They inhale it. It's kind of irritating. And so he was not immediately accepted. And in fact, one of his major opponents was a guy in Philadelphia named Samuel Gross. This is a painting called The Gross Clinic by Thomas Eakins. It's probably one of the more famous medical pictures. You may have seen it before. And Gross was an early pathologist and surgeon, and he thought that the reason surgical wounds went bad and killed people was because of oxygen. He said, well, the oxygen oxidizes the wound. It's going to cause horrible things to happen in the body, and that's why we need to be fast. So we need to be fast to get through it. And surgeons, back in those days, with no concept of antisepsis, germ theory, they wore overcoats that were just caked with filth and pus and blood, and the dirtier the overcoat, the more kind of a status symbol it was. So people would come in just caked with filth. If they dropped their scalpel on the ground, they'd pick it up, maybe strop it on the bottom of their leather soled shoes to sharpen it a bit and go right back to it. And so that was what surgery was. And so Lister was asking these people to really fundamentally changed their entire approach to surgery, and he got a lot of resistance. But Lister personally had one of the attributes we've seen very little of in this series of talks. He was incredibly persistent and humble and patient and a great communicator, and he kept on trumpeting the benefits of this antiseptic activity to the point that 20 years afterwards, antiseptic protocols had become the standard. He was never really embraced in England or America until much later, but other European countries who were made aware of these procedures really adopted them quickly because they realized the numbers didn't lie. The people surviving these procedures due to antiseptic activity was undeniable. So his findings were validated with superior outcomes, his persistence, his humility, and his ability to kind of stick in a good cause despite being told he was, completely wrong. And one other way that we undervalue, but tends to be a major way progress happens, which is he outlived his opponents. Young, new people bringing new, exciting theories often find that they're fighting against an entrenched status quo. Well, guess what? Those people in the status quo don't last forever. So that, sadly, is one way that progress gets made, is those old barriers disappear. So eventually we figured out that you didn't have to do asepsis if you actually had or antisepsis if you had an aseptic environment. If you had things that were never exposed to bacteria in the first place, you autoclaved things, an aseptic environment was actually better than an antiseptic one. And the same guy, Thomas Eakins, did this picture about 20 years after the Gross Clinic, showing a big difference. We've got more relaxed, we've got white coats because people don't want to hide the gore, the blood, and everything that's soaked into their gear. And so this is called the Agnew Clinic, and it was actually commissioned for Dr. Agnew's retirement, the guy on the center left there, and painted by the same person who did the Gross Clinic. So American surgery was really taking a big step forward. We had come up with the process of anesthesia. We were not early adopters of antisepsis, but once it became known, people started to use it more. Now, just like physicians, surgeons generally, if they had the money, if they were American, they would go to train in Europe. That was the high status area. American medical education was pretty lousy. We talked about how that changed with the advent of the Flexner Report. But before that, people with means, like William Halstead here, would go travel through Europe and get their training there, then come back to America and set up a practice. So he got exposed to Lister's methods in Europe and brought them back and he was told he couldn't have an antiseptic theater in his hospital in New York, so he actually built a tent on the grounds that became an antiseptic tent and did procedures there. He was on fire. He did lots of surgeries. He had a very active social life. He wrote lots of papers, and he and his friends were just doing research all the time, doing lots of procedures, and he was just skyrocketing the top of the medical world. The problem is someone told him, oh, you should check out this new topical anesthetic that people are using, It's called cocaine. So he started experimenting with using cocaine as a peripheral nerve block. We could figure out how to knock people out with surgical anesthesia, but peripheral nerve blocks where someone was put under a local anesthetic, that was still new ground. And so that's what they were investigating cocaine as. So he and his friends would inject cocaine and write down the results. And they started to notice, man, I feel really good. We should go out on the town. So they would just go nuts because they were researching cocaine, but they were having the euphoria that comes with it. Now, we already mentioned cocaine was being, it was extracted from the coca leaf first in the 1800s. Sigmund Freud took a look at it, but totally missed the nerve blocking potential of it. He was focused more on using it as a way to cure people from addiction to morphine. Didn't really pan out. Told Carl Kohler about it, and he used it for using eye drops, cocaine eye drops for anesthesia, for eye procedures. But this is before the Food and Drug Administration really had any hand in taking care of these things. So guess what, kiddos? Your gums hurt? Have some Coke. Medicines, heroin, opium, cocaine, you could just go down to the corner drugstore, buy as much as you want, and nobody really had any sense that this was something that had to be watched for. So it was very much out there. People could use it and abuse it, and clearly they did. So Halsted, let me back up a second. Halsted got addicted to cocaine, as did many of his friends they were doing this research on. They had no idea that it had that property, but it basically drove them into the dirt. They had become full-on addicts. They couldn't work effectively anymore. They were very much just kind of taken low. I think several of his friends actually died due to overdose. And after years, he finally published his paper on the use of cocaine as a topical anesthetic. But he was so addicted to it and so strung out that it was almost nonsensical. Now, I've picked one sentence. I've cherry-picked it. They're not all like this, but I've cherry-picked one sentence from his paper, and I'm going to read it just because that's the only way you really get the full impression of what coke had done to him. Neither indifferent as to which of how many possibilities may best explain, nor yet at a loss to comprehend why surgeons have, and that so many, quite without discredit, could have exhibited scarcely any interest in what, as a local anesthetic, had been supposed, if not declared by most, so very sure to prove, especially to them, attractive. Still, I do not think that this circumstance of some sense of obligation to rescue fragmentary reputation for surgeons, rather than belief that an opportunity existed for assisting others to an appreciable extent, including me, several months ago, to write on the subject in hand the greater part of a somewhat comprehensible paper which poor health disinclined me to complete. Huh? Yeah, so clearly he had suffered greatly at this, and he was addicted to cocaine for, very badly. And that might have been it. But thankfully, he had a really good friend, a guy named William Welch, who had become the department chair at a brand new hospital. This was Johns Hopkins. And he said, come on, let's come down to Baltimore. You can work in my lab. You can get healthy. You can try to recover your health. And so Halsted came into his lab, worked there for several years before the medical school opened. And he transformed from this kind of just rapid fire man about town to a very slow, meticulous operator. And it's said that his surgeries were nearly bloodless because he took so much care to ligate and take care of every little vessel that, the surgeries were fantastic, but it was very slow paced. And his surgical techniques were incredibly conservative, but he started researching ways to do surgeries that no one had ever thought of before. He did the first thyroid operations that actually worked. He figured out how to bring intestines together, do an intestinal anastomosis using the submucosa to anchor the suture. Otherwise, it was going to tear free. He worked on how to fix aneurysms, and he actually did one of the first gallbladder removals on his mother. His mother had an infected gallbladder, and she was having a massive gallbladder attack. So he had his dad and brother hold her down on the kitchen table, and he operated on her, took out her gallbladder, and fixed her. He knew what he was doing, and he'd been practicing it, but turned out that he actually needed to do that to his mom first. The bottom left is showing one of his illustrations. These are actually all his illustrations. He was a very gifted artist, too. And he did a lot of studies on how to put the tissues together, how to repair inguinal hernias. This was the first effective practical hernia repair that had ever occurred. And he created something called the Halsted radical mastectomy. Now, When you hear about the radical mastectomy these days, it's kind of talked about in a very underhanded way. It's a brutal, brutal procedure. What you do is you take off the breast, both pectoral muscles, as much of the lymphatic tissue leading toward the axilla that you possibly can, and that's it. We have a lot better options now. We have lumpectomies, we have earlier screening, we have better ways of tracing how the tumor has spread. But at the time, this was the first surgery for breast cancer that actually worked. Breast cancer was a death sentence, and not only a death sentence, but it was one that sent people into their homes, into seclusion, because they had festering sores that would go bad and would smell terrible. And people just died very slow, agonizing deaths. This was the first process that actually worked. And to give you some idea about the status of breast cancer surgery prior to Halsted, here's what you did. You have somebody, top left, smoke opium, and you stick spikes through their breast. You then anchor ropes to the spikes and pull upward to put traction on the subcutaneous tissue of the breast. You then take a hot knife and cut the breast off, and then apply cautery to seal it. The calm, stoic expression on the woman in this illustration could probably be nothing further from the truth. And think about lymphatics, think about tissue, think about how cancer spreads. Is this actually going to fix anything? No. So again, the Halsted radical mastectomy, we've got better options now. They still occur occasionally, but it was a huge step forward. And this is from Halsted's own illustration of the process. Take a look at the realism and the understanding of anatomy that's present there. So more effective options exist now, but at the time, this was a huge, huge step forward. He also kind of adopted and made the current residency system of, which we're all familiar with, kind of in practice in surgery, where juniors train, or where seniors train juniors, and then those new juniors train even more junior surgeons. And if you happen to enjoy wearing latex gloves in the anatomy lab and in medical practice, you can thank him too. He's the first person to come up with surgical gloves. Before then, it was all barehanded. And he, as an upper class New Yorker, thought to himself, my surgical nurse, her hands keep on getting red from all this antiseptic material we use. I should call the people at Goodyear and see if they can make her a glove. So, rubber gloves came in. He actually wound up marrying that nurse, a woman named Carolyn Hampton. And one thing about the residency system that's always fascinating is it allowed surgeries to happen even if the top dog wasn't there. If the chief isn't there, then the residents can do it, the juniors can do it, you keep on training. This was very important because he was very unreliable. He would occasionally disappear for months at a time. And the reason is he may have kicked his cocaine habit, but he did so by getting addicted to morphine. And he remained a morphine addict for most of his life thereafter, and he would occasionally go on benders and just disappear to his country home, come back later. But the residency system allowed the process to keep working, and the fact that he did so much, it's just heartbreaking to think what he could have done if he didn't have that yoke, that lodestone anchored around his neck his whole professional life. But he was able to continue and be productive despite that massive addiction. And this was something that was only really brought to public attention after his death. A guy named William Osler, a very famous physician at Johns Hopkins, also wrote a quote-unquote secret history that was only published after his death, in which he kind of detailed all the drama behind the days at Johns Hopkins. Now, various organs started to become more available for exploration. Heart surgery became practical in the 40s and 50s, but brain surgery, very difficult. The brain is not a solid organ. It's pretty loosey-goosey. And these are the days before we have medical imaging techniques. X-rays were just coming on the scene, but think about X-rays. They don't really show you much of the brain. So a guy named Harvey Cushing was trained by Halsted. He really didn't like him. Halsted was very aloof, kind of made a lot of sarcastic comments, but he really liked William Osler, that other physician who was professor of medicine at Hopkins. And in fact, Cushing was yet another surgeon and artist. He did this drawing as well. It's actually William Osler being shown with the craniotomy there. But he used cocaine as a topical anesthetic. He didn't actually use it himself. It was well known at that point to be addictive, but he figured out you could use it as a local anesthetic and treated trigeminal neuralgia. First treatment for that, cerebral hematomas, actually getting the blood out of the skull when you had an epidural or subdural hematoma, as well as pituitary problems. So he was one of the first effective neurosurgeons, and trigeminal neuralgia, we've talked about that. So trigeminal neuralgia, you get massive pain along a branch of your trigeminal nerve caused by the lightest of touch, lasts for a very long time, doesn't let people sleep. Before this surgery, the inevitable outcome of trigeminal neuralgia was suicide. People could not take the pain, they couldn't sleep. If you can't sleep, you don't make very good decisions. And so he would go in and he actually cut the entire trigeminal nerve. That was better. That was better than having this pain coming at you seemingly randomly. So he did well over 2,000 operations, and brain operation mortality dropped to about 8% from 90% during his lifetime. He pioneered a lot of that. And like a lot of surgeons, he had kind of a rival, a guy named Walter Dandy. These two were kind of friendly rivals, depending on which books you read, friendly or not so friendly rivals. But Cushing was kind of upper class. He was from Cleveland, but he was kind of old money. Walter Dandy was kind of the young upstart from a poor background, and he really tried hard to leave an imprint on neurosurgery. He figured out how the CSF circulates, why hydrocephaly occurs. He came up with aneurysm clips, and also he's the guy who figured out that a herniated nucleus pulposus is what can cause sciatica or other nerve impingement issues. He also came up with a imaging process called pneumoventriculography. This is weird. So let me set the stage for you. At this point, if you wanted to do neurosurgery on somebody, you had no imaging modalities available. Meaning, if you thought there was a tumor in their brain, you had to decide where to cut into their skull based only on the neurologic exam. So you had to do a really thorough neurologic exam to say, okay, we're cutting here, not here. And if you screw up, you open up the brain and boom, nothing's wrong in the spot you just opened up. So finding a way to image would be great, but x-rays, especially then, are not going to show soft tissue like the brain. So Walter Dandy had this amazing idea. I'm amazed anyone had the willpower to see this through. He did a craniotomy, drained the fluid, CSF from the ventricles, took an x-ray, and at that point the air in the ventricles gave contrast, and you can actually see their outline and see if there was a tumor in the ventricles, then sutured the person back up and let CSF gradually refill the ventricles. So that's what they were reduced to doing in order to actually visualize anything in the brain. So next time when you guys get to order CTs and MRIs of the head, just give a nice little prayer up to whatever higher being you subscribe to, because it's so good to be able to take pictures of things rather than relying on a neuro exam and pumping air into their ventricular system to take an x-ray. So Hopkins is also justifiably known as the place where heart surgery became possible, and that's because of this woman, Helen Taussig. She became famous, along with some others, because of the first practical operation around the heart. Now, she was a Hopkins grad. Hopkins allowed women into school, but she really didn't get she'd been discouraged from being in medicine her whole life, but persisted, went to various schools, eventually was able to get to Hopkins, graduated, but she was given a cardiology fellowship and was basically put in a pediatric cardiology unit. Now, at that time, pediatric cardiology was just making these little children as comfortable as possible until they died of their heart defect. But she was never really, keen on just letting it happen. She consulted with another woman from Canada, Maud Abbott, who was an expert on congenital heart defects, and started looking at the different types of heart defects that Maud Abbott had collected and trying to diagnose them in her living patients. She had a fluoroscope that she would use to inject contrast media in the bloodstream and see how it spread through the pediatric heart and see if she could figure out where the defects were that were responsible. So this is a very famous picture of her, but it's completely staged, and I want you guys to get very osteopathic proud in a moment here. because she, by the time she was practicing, was mostly deaf. She'd had scarlet fever early in life and had lost a lot of her hearing. And by the time she was middle-aged, her hearing was pretty much gone. She had this big, bulky hearing aid, but it didn't really work well. She figured out how to palpate the children in her clinic and palpate their thrills, their murmurs, the different bits of the vibrations of the heart, the turbulence that would be encountered. She was able to palpate all of that through that. So she listened with her fingers. Now, she was an MD. We can't claim her, but you can indeed palpate things like heart defects. She's proved it. So she palpated those valvular defects, said, learn to listen with your fingers. And she actually came up with a textbook on congenital malformations of the heart. She created pediatric cardiology. And, as a woman in medicine, as a Hopkins graduate, it was expected she had equal treatment. In reality, that's not so much. She came up with all of this stuff, but still didn't become full professor until about 20 years thereafter. So the bar was still higher than it should have been. But let's talk about the blue baby operation. She had patients with tetralogy of Fallot, and she noticed something, that the patients who had tetralogy, but also had a PDA, a patent ductus arteriosus, they did better. And if that patent ductus closed, they went downhill quickly and died. So she realized that these people with a heart defect would do better if there was a connection between their aorta and their pulmonary circuit that bypassed the part of the heart that was affected by tetralogy. But she was not a surgeon. She didn't know anything about actually repairing it directly. So she talked to the chief of surgery at Hopkins, a guy named Alfred Blaylock on the left. And he had just come from Vanderbilt, where he and his lab assistant, Vivian Thomas, had worked on surgical shock. And the way they dealt with it was by trying to combine the axillary artery with the pulmonary artery to create a type of surgical shock and lower the blood pressure. Now, Vivian Thomas wanted to go to medical school, but all of his savings were wiped out when the bank he kept his money in collapsed. Back then, there was no federal deposit insurance. If your bank failed, guess what? Money's gone. And he'd worked as a woodworker. He was very skilled with his hands, and he started work in this lab, and Alfred Blaylock realized that Vivian was incredibly skilled and was able to start doing a lot of the surgeries that he wanted to have done on dogs and cats, that they were exploring ways to do surgeries on people thereafter. So pretty soon Vivian was running Dr. Blaylock's lab, and Blaylock actually talked Vivian Thomas from moving from Nashville to Baltimore, which for a black man at the time was a big change. Nashville was actually a fairly... Is Vanderbilt in Nashville? Yes, okay, I got it right. It was actually a very high culture center of black American culture. Baltimore, not so much. Very racist. But he talked Vivian into moving there with him, and they set up a laboratory at Hopkins that was the kind of cutting edge for heart surgery. And so he consulted with Helen Taussig, and they thought, well, what we need to do is figure out a way to build an artificial ductus for these kids with tetralogy. So they started experimenting with smaller and smaller puppies, and eventually there was a patient named Eileen Saxon, a little 3-year-old girl, and she was going downhill fast. And basically her parents had agreed to the surgery on the chance it would elongate her life. And Helen Taussig said, this surgery has to happen now if she's going to be survivable at all. We have parents who are willing to let this happen for us to do this. So Blaylock scheduled the surgery. Here's the problem. He had never done it. The only person who had done this surgery up until now was Vivian Thomas, his lab assistant. So Blaylock scrubbed in, started the surgery, and suddenly stopped it and said, I need Vivian here right now. And so the chief of surgery at Hopkins performed this first heart operation with his lab assistant, his black lab assistant, over his shoulder on a stool, being like, no, don't shoot you there. Okay, take your finger that way. Okay, go ahead and unclamp. Things like that. And no one really knew if the surgery was going to work until they removed the last clamp, and this little girl who had been cyanotic, blue her whole life, flushed pink all at once. And that was very dramatic, and pretty soon these operations started happening all the time. People were bringing their children, their kids with tetralogy in from Hopkins all over the place. If you want to see a dramatic version of this, Alan Rickman and Mos Def starred in it. It's called Something the Lord Made. Ugly crying. Ugly crying is how I would describe the end. So it's really good. And if you want to see Severus Snape talking with a southern drawl, you could do a lot worse for entertainment. So great movie. So basically this Blalock-Taussig shunt, notice it's not the Blalock-Taussig-Thomas shunt like it should be, but this Blalock-Taussig shunt became a real game changer. It was the first surgery to correct a heart defect and became the standard of care until, in 1953, people came up with the heart-lung bypass machine, meaning you could stop the heart, keep the blood circulating and oxygenated, and actually repair the defect in state. But a lot of people who had the Blalock-Taussig shunt survived long enough to have that done because that operation succeeded so well. Vivian Thomas did receive an honorary MD from Hopkins in 1976, very belated, but despite not being able to go to medical school, he was part of this groundbreaking research and pretty much had a hand in training every pediatric cardiologist in existence at that time, because they all were training with Helen Taussig and Blalock at Hopkins. So we move from surgery of the brain, surgery of the heart, to other organs, and one of the things that's always been kind of a gold, kind of a gold standard for what we're striving for was heart surgery, but also organ transplantation. The first kidney transplant was actually done between twins, and this was actually done with extreme, over the objections of a lot of people at the hospital. But Joseph Murray, who did this, won the Nobel Prize for it, even though it took about 40 plus years for it to be recognized. But he was able to come up with how to transplant kidneys. But the problem is, the surgical know-how wasn't the problem. What's the problem with transplants that we're running up against? Rejection. The immune function of the body was barely understood, nowhere near the level we have now. And in fact, immunology is just proceeding by leaps and bounds. It's the hot science of the moment. And rejection was just known to be a fact of life. People didn't know how to deal with it. So at Stanford, we had two doctors, Richard Lower and Norman Shumway, working on transplanting hearts for dogs to try to come up with a way to do it for people. And they had lots of people coming through their lab, but they were proceeding very cautiously. They knew the rejection phenomenon was a problem. So imagine their surprise when they opened the newspaper one day and find out that a student of theirs, a guy named Christian Barnard from South Africa, had done a heart transplant in Cape Town. Now, the heart transplant was a success, meaning it was put in there, started beating, the person survived, and this became news everywhere, and heart transplants started happening all over the place. The problem was the rejection phenomenon was not well understood. These people might live for another couple months, but that's a couple months after open heart surgery, split sternum, healing, and eventually this tissue was going to be rejected by the body. So it was an advance, but the heart transplants took off, and as the outcomes kept on being poor, they eventually stopped. But thankfully, Shumway and the other people at Stanford figured out, that there was a way to depress the immune system. They found cyclosporine was actually able to depress the rejection phenomenon, not completely get rid of it, but if you immunosuppressed someone, that would stop the transplant rejection from happening. Now, obviously, immunosuppression has other problems. It's not something that you can do without any consequence, but it allowed people to survive into more and more years after a transplant, and then not only heart transplants but heart-lung transplants, other organ transplants were happening. And by the time we were in the 80s, transplantations technically weren't the problem. It was enough donor organs being present that became the problem. And at one point, baboon hearts were looked at as a viable option. I believe someone just received a pig kidney earlier, this week or last week. So we'll see if those animal to human transplants are feasible. But new horizons in surgery are going to be involving finding ways to replace organs that have gone bad. And regenerative medicine, once again, major field for advancement. So in 2006, up at Wake Forest, a lab-grown bladder was made for a child with spina bifida. This kid had a bladder that was non-functional because of the spina bifida, and it was tonally contracted, and so the kidneys couldn't get urine through the bladder to the urethra. And so instead, these scientists came up with a way to take cells from the kiddo that were connective tissue, decellularize it, and then painted stem cells from the kid, his bladder, onto that scaffolding and grow a bladder that was then transplanted and create urinary sphincters. A lab-grown trachea, shown here, was transplanted from the patient's own stem cells. So people want stem cells to be able to create whole new organs, but it looks like stem cells plus 3D tissue printing is going to be the thing that really helps us out right now. And in addition, as they're 3D printing meat, non-animal meat, we're also figuring out how to create organs that might come from the cells of the person who's actually receiving them. And the trick is finding those pluripotent and totipotent stem cells in a person's body that can then be directed to form cartilage or bone or muscle or epithelium, and then putting those onto that scaffold. And that pretty much takes us up to right now. All right. This is the second to last talk. The next one, I'll get the date out to you guys. It had to shift a little bit to accommodate Quiz Bowl, but it's going to be looking at opportunities that were missed. We've talked about a lot of the false starts and things in medicine that didn't work. Now we're going to look at how medicine kind of faltered, how people were excluded, eventually got back into being able to practice medicine, but also just some of the false steps and this really twisty, curvy history of medicine and how things got overlooked, lost, and then rediscovered later. Okay, we finished early even. This was scheduled for 2 hours. It's been a pleasure. I'll see you guys soon. Happy Easter. Happy holidays.